All right, let's talk about something you are absolutely going to see on the wards and in the ICU, respiratory acidosis. Now, when this pops up, things can get serious really fast. But here's the thing, truly understanding it is like a clinical superpower. So today, we're going to crack the code together.
So, picture this. It is 2 in the morning, of course it is, and you get paged about a patient. Known history of COPD, and the nurse says he's confused and really struggling for air. You get there, and he looks tired. You need answers, and you need them like 5 minutes ago. What's the one test that's going to give you the fastest, clearest picture of what's going on?
You guessed it, the arterial blood gas, the ABG. Look, this is so much more than just another lab value. Think of it as a direct snapshot, a real-time window into your patient's physiology. It is the key that is going to unlock this whole mystery for us.
Okay, and here are the numbers from our patient. Let's break this down. First thing you look at, pH. It's 7.25. Well, normal is 7.35 to 7.45, so we are definitely in an acidotic state. Now look at the PaCO2. It's 60. Normal is 35 to 45. That is way high. And right there, those two things together, a low pH and a high CO2, are screaming at you, this is a respiratory problem.
So this is the textbook definition, but let's make it way simpler. Your lungs are basically the exhaust pipe for your body. They're supposed to get rid of the waste product, carbon dioxide. When they can't do that job properly, what we call hypoventilation, that CO2 builds up. It's literally under-breathing. Not enough air is moving in and out to clear that waste. And this is the magic behind it all. It's pure chemistry. That CO2 that's building up doesn't just hang out. No, it immediately combines with the water in your blood and poof, it becomes carbonic acid. So you have to get this in your head. More CO2 literally means more acid in the system. It's that direct, and that's what makes it so dangerous.
Look, when you get an ABG back, don't just stare at the numbers. Have a system every single time. It's this simple. 1, look at the pH. Is the body acidic or alkaline? 2, look at the past CO2. Is it the cause? Quick tip, if the pH is down and the past CO2 is up, they're going in opposite directions, that points right at the lungs. And 3, look at the bicarb. That tells you what the backup system, the kidneys, are doing about it.
Okay, so we've nailed the what. It's respiratory acidosis. Great. But that is only step 1. Now we have to put on our detective hats. The real clinical work begins now. We have to figure out the why. Why is this specific patient not clearing their CO2?
The why is always hypoventilation, but the cause could be anywhere. You have to run through this mental checklist. Is it the pipes themselves, an airway obstruction like in our COPD patient? Is it the brain, the central command center being depressed by something like opioids? Are the nerves and muscles that do the work of breathing failing, or is it a mechanical problem with the chest wall itself? You got to think through all of these.
And this is where physiology gets so cool. Your body is smart. It's a fighter. It doesn't just let the acid build up and say, oh well, no way. It has powerful, built-in systems to fight back and try to fix that pH. Understanding this fight is key to figuring out your patient's story. And this brings us to a really critical fork in the road. Is this problem brand new, acute, like a sudden overdose, or has this been going on for a long time, chronic, like in our patient with COPD? The answer tells you how to manage them, and you find it by looking at how well the body has had time to fight back. Let's look at these two patients side by side. Check it out. They both have the exact same high PaCO2 of 60, but their stories are totally different. Patient A has a scary low pH and a totally normal bicarb. This just happened. Their body had no time to react. Now look at patient B. Their pH is almost normal. And why? Because their bicarb is 31. Their kidneys have been working overtime for days, maybe weeks, to buffer that acid. So how does the body pull this off? It's a two-stage defense. First, within minutes, you get some buffering right in the blood. It's a quick fix, but it's not very powerful. The real hero of the story is the kidneys, but they're slow. They take 3 to 5 days to really get going, holding on to bicarb to neutralize the acid. So think of it this way. Blood buffering is the sprint, but renal compensation, that's the marathon. All right, lean in for this one. This is a fantastic clinical pearl, a piece of bedside magic you can use. In a chronic situation, the kidneys are amazingly predictable. For every 10 points the PaCO2 goes up and stays up, the bicarb will go up by about 4. So for a chronic CO2 of 60, like our patient,
That's 20 points high. We'd expect the bicarb to be up by about 8. It's a great mental check to see if the compensation fits the story.
Okay, back to our patient. They have COPD, they're retaining CO2, they're probably short on oxygen. So, the obvious move is just to crank up the O2, right? Help them breathe. Well, be careful. This is one of the most classic, most dangerous traps in all of medicine.
So why is this so risky? In a healthy person, high CO2 is the big, loud alarm bell that screams at your brain, breathe. But in someone who has had high CO2 for years, their brain kind of gets used to it. It tunes out that alarm. Instead, it starts relying on a backup alarm, low oxygen or hypoxia. If you come along and blast them with 100% oxygen, you silence that backup alarm, and their brain might just stop trying to breathe.
So what's our playbook? Number 1, always treat the underlying cause. Give bronchodilators for that COPD. Number 2, be smart with oxygen. Start low, go slow. We're aiming for a safe oxygen level, maybe 88 to 92%, not 100. 3, help them breathe. Non-invasive ventilation, or BiPAP, can be a total game changer, acting like a little power assist for their lungs. And finally, don't be a hero and try to fix the CO2 in 5 minutes. Correcting it too fast can cause huge problems.
And this really is what it's all about in the ICU. It is a high-stakes balancing act. Every single move you make, how much oxygen, when to use BiPAP, how you manage their sedation, it all has a massive impact on whether that patient gets better or worse. It's a constant tightrope walk. Now this right here, this is some senior-level wisdom. This separates the rookies from the pros. Your goal is not to chase a perfect pH of 7.40. If you try, you'll often overshoot and cause more harm. Your goal is to get the patient out of the danger zone. A pH of 7.25 is often totally fine. We're treating the patient to be safe, not to have perfect numbers.
So let's wrap this all up. Remember, the ABG is an incredible tool. It tells you the what. It gives you that physiological snapshot. But your job, as a thoughtful, brilliant clinician, is to always dig deeper, to find the why. Because you're not just treating numbers on a lab report. You're treating a person. You're treating their story.